Hello, everyone, and thank you for joining our monthly webinar. It's a DMC Medical Group Heart-to-Heart monthly webinar come to you on the fourth Thursday of the month at 7 p.m. Eastern Time. I'm really privileged to have our co-host, Dr. Kenton Zer. He's the Director of the Cardiovascular Service Lines at DMC. My name is Shad Reyes. I'm the co-host for this series, and we're really privileged to bring you kind of up-to-date topic and also topics kind of covers diverse disease state as well as up-to-date in medicine, as well as in surgical intervention. As a reminder to the audience, this is a our CME accredited. Comes to you free. All what you have to do is to fill the survey that comes to you the following day about the webinar, and take this opportunity to give us feedback about this webinars and others, and if you have any suggested topics. All these webinars are recorded, edited, and also uploaded and hosted on our YouTube channel. You can find all the topics that has been covered before, starting from surgical intervention, aortic valve, mitral valve, minimally invasive COVID topics, as well as other interventional topics. With that, we'll start with a video, and then we'll introduce our speaker for this month. Coming to you from the...
It weighs less than 1% of our body mass and is an engine that never stops, pumping almost 2,000 gallons of blood along 60,000 miles of blood vessels every day. Our hearts perform like nothing under the sun. So when your heart needs care, you want a team of experts, board-certified heart and vascular surgeons with over 40 years of combined surgical experience, trained at some of the nation's top institutions, like Johns Hopkins University and Mayo Clinic. True specialists in the fields of non-invasive cardiology, interventional cardiology, cardiac electrophysiology, cardiothoracic surgery, and vascular surgery. For over 3 decades, our specialists have been available in Commerce and Detroit because we believe heart care isn't something you wait for. DMC Medical Group, trusted by the hearts of Metro Detroit.
All right, everyone, with no further ado, I would like to introduce our guest speaker for this month. I'm pleased to introduce to you Dr. Peter Cesalos. He has recently joined the Children's Hospital of Michigan as a pediatric cardiovascular surgeon. Dr. Cesalos comes to us from University of Michigan, where he was an assistant professor of pediatric and cardiovascular surgery. He is board certified in general surgery, adult cardiothoracic surgery, and congenital heart surgery. In addition, Dr. Cesalos has extensive experience in neonatal, pediatric, and adult congenital heart surgery. His surgical specialties include infant and pediatric cardiovascular disease, adult congenital heart disease, and Dr. Cesalos believes in multidisciplinary approach to care, which include the parent and family as part of the team, along with giving referring physician timely updates on the status of the patient they entrust to his care. His goal is to allow pediatric patients to live the fullest life possible with the best quality and least number of intervention. Please welcome Dr. Cesalos. And Dr. Cesalos, thank you so much for being with us. I'll give you the ground to show.
Great. Well, thank you again. I look forward to giving this presentation. I know that it's a diverse audience with different backgrounds, so I hope that this appeals to all of you. I wanted to speak about adult congenital heart disease for the non-congenital heart surgeon. I have no disclosures. So just to give you perspective as an introduction, congenital heart disease is the most common birth defect. It affects nearly 1% of US births per year, about 40,000 babies. And about a quarter of those patients are defined as having critical congenital heart disease, meaning having an operation within the first year of life. One of the most severe forms is hypoplastic left heart syndrome, with about 1,000 babies a year. And currently it's estimated that about 90% of patients are expecting survival to 18 years old for most severe disease. The reason that that's important is that the early efforts in this field were really aimed at survival. So 30, 40 years ago, a lot of these children were not surviving. But with improved survival, the focus has now shifted on continued survival, but also on the associated morbidity and neurodevelopmental outcomes. So given the good success over the last 50 to 60 years within this field, there's now an estimated more than 2 million patients living in the US with congenital heart disease. And there's actually more adult than pediatric patients with congenital heart disease. And that's the reason for this talk today, and the special interest in this field is that really adult congenital heart disease requires a strong understanding and a multidisciplinary approach to care to meet their complex needs. And also there's a significant impact. These patients and their care have a significant impact on the healthcare system. So as a general outline, I wanted to talk about some general principles of care when you think about these patients, discuss the diagnostic and therapeutic options available just as a general summary. And then I wanted to provide you a classification of adult congenital heart disease, and then provide a spectrum of that disease. And then I wanted to really discuss some commonly encountered lesions. So the thing with this field is that there's a lot of variability in the lesions and presentation, and a lot of the patients are very different in terms of their anatomy being complex and the repairs they've had. But I think it's most useful that we focus on some of the commonly encountered lesions that you'll see. In terms of principles of care, as I said, it's important to know that these patients are complex and they pose many challenges. I think a very important point is that there needs to be a smooth transition of care from childhood to adulthood with these patients. And there needs to be access to care of adult congenital specialists. And because of all that, you really need a coordinated multidisciplinary approach. And that would be most useful to manage both cardiac and non-cardiac disease in these patients. And having proper use of available diagnostic and therapeutic approaches is really required to allow these patients to have the best life and best results. So this is the multidisciplinary team, to name a few. It's by no means inclusive of everybody, but I think it emphasizes the point. And I really believe that to care for patients with adult congenital heart disease, you really need to have the infrastructure and support to be able to provide all of these services. So in the center is the patient, of course. And so starting at the top, we have both pediatric but adult cardiovascular surgery. Same thing with cardiology. It's important to have both pediatric and adult cardiology, to have echo, EP, and cath capabilities, advanced imaging with CT and MRI. You have to have heart failure, transplant, and mechanical circulatory support options, perfusion and ECMO, all of the medical and surgical subspecialties, primary care with family medicine, internal medicine, pediatrics, an intensive care unit, anesthesiologists, and then nursing and mid-level providers, and then all of the ancillary support, respiratory therapy, physical therapy, OT, pharmacy, et cetera. And really all of these members of the team are critical to care for these patients. So just a few special considerations when you're caring for one of these adult congenital heart disease patients. I think it's important to know they're adults, but also because of their pediatric history, a lot of them have underlying chromosomal associations or neurodevelopmental abnormalities that really play a role in the management. It's also important to understand the significance of their underlying anatomy and surgical repairs. So just for example, a patient who's had a classic platelet Tausig shunt will have diminished pulses on the side of that shunt. So just in terms of simple blood pressure measurements, it's important to know information like that. Another example is a patient with tetralogy of Fallot typically has a large ascending aorta, but that's very different than a patient who has a bicuspid aortopathy or Marfan's aortopathy, and they behave differently. So having that understanding of the disease process is important in the management. It's also important to know that these patients, given their complex histories, have very challenging and unreliable vascular access. There are certain diseases that have very specific guideline-directed management. And this is where I think it's important to have experts in adult congenital care to be able to guide this in a shared fashion. So a good example is long-term Fontan surveillance of liver disease. It's always important to keep in mind endocarditis prevention in these patients. And it's also important to remember that although they have congenital heart disease, they're adult patients who also develop acquired disease, and we need to consider them in that way as well. So just as a general armamentarium of options available, and I didn't go through these for each lesion, but I think just as a group, it's important to know that most of these patients get routine workups that include laboratory studies, an electrocardiogram, chest radiograph and a transthoracic echo. But then there are indications where you need additional imaging. And so, for example, some anatomy is difficult to visualize and a transesophageal echocardiogram is helpful. Cross-sectional imaging is very helpful, either to evaluate pulmonary veins, aortic pathology, different things like that with a CT scan, coronary artery anomalies. And MRI and MRA are helpful in terms of providing both anatomic data, but functional data. Lung perfusion scans, PFTs, liver and vascular ultrasound, cardiopulmonary exercise testing, and of course, cardiac catheterization. And so depending on the patient, a lot of these diagnostic modalities will be required. And then just broadly speaking, in terms of therapeutic interventions, I always think of patients, and I think of 4 different treatments for every patient, from least to most invasive. And I brought these up just to bring a little discussion to this as well. So first of all is lifestyle modification, exercise, diet, risk factor modification, medical management, which you're all familiar with. And then there's catheter-based intervention. And I put here specifically that catheter-based intervention can be by a pediatric cardiologist. An example would be a catheter pulmonary valve, by an adult cardiologist. So a lot of these patients will need percutaneous coronary interventions. We've even had complex congenital heart patients that require TAVRs, or as a joint procedure between 2 interventionalists. And that holds true also with surgical intervention, that it's really a shared mission between congenital heart surgeons and adult cardiac surgeons. And so both the surgeon and the location are important. And some of this is institutional dependent. Some of it's related on other factors, but there are patients that would be best served by a congenital heart surgeon in a pediatric hospital. There are other patients that would be best served by a congenital cardiac surgeon in an adult hospital. Those would be patients that have more simple congenital heart disease, but have significant comorbidities. There are patients that would be better served by an adult cardiac surgeon in an adult hospital. So although their congenital heart disease is present, maybe their acquired disease or their comorbidities would make that more important. And then joint procedures where it's the expertise of both surgeons that are leading to good outcomes. So next I'd like to touch on how to classify adult congenital heart disease. There are many ways to do so, but I think that a reliable way is to base it on the 2018 American Heart Association and American College of Cardiology guideline for the management of adults with congenital heart disease. And they really define the classification based on the anatomy, the surgical repair, and the current physiology. And these guidelines, if you're not familiar with them, provide a strength of recommendation with a level of evidence to guide management. And I put this here just as reference, but in terms of all of these guidelines, and they have them for acquired heart disease, valvular heart disease, all different types, but they really look at a strength of recommendation from class 1 to class 3, class 1 being a strong benefit, class 3 being more risk than benefit. And then the quality of evidence is from level A through C. Level A is high quality data based on randomized controlled trials, a large meta-analysis of randomized controlled trials. And then level C is based on expert opinion. And one thing to note with congenital heart disease in general and adult congenital heart disease is that oftentimes sample sizes are smaller and there's less randomized controls. And so sometimes it's hard to provide a higher level of evidence versus, for example, adult cardiology, where you have many studies with large numbers of patients. So in terms of a classification system, the first part of it is based on the anatomy. So they define patients based on either simple, moderate, or great complexity. And that can be both of their native disease or their repaired disease. So just for example, on this classification system, simple complexity native disease would be a small atrial septal defect, where simple complexity repaired disease would be a prior patent ductus arteriosus ligation. Moderate complexity native disease would be an atrioventricular septal defect, and repaired disease would be status post-tetralogy of Fallot repair. And then great complexity would be any single ventricle physiology. and Fontan. And these are just a few examples to give you an idea. But this doesn't really define the patient appropriately. So the next step is then to look at the physiological variables. So they have a list of variables that they feel, based on consensus, have a significant impact on prognosis and management of these patients. So those include aortopathy, arrhythmia, concomitant valvular disease, end organ dysfunction, exercise capacity, cyanosis, New York Heart Association functional status, pulmonary hypertension, the presence of significant shunt or venous and arterial stenoses. And based on these variables, they assign the patient a physiological stage A through D, A being the best and D being the sickest patients. And then they combine that anatomy, complexity, and physiological stage to give a classification. And so again, it's from 1 through 3 and A through D. So for example, a patient who's a 2B is an AVSD with a class 2 symptoms, so relatively healthy patient, where a 3C would be a patient with a Fontan procedure with end organ dysfunction responsive to therapy. And this classification system is important because it allows us to think about these patients in terms of their complexity and to think about them in terms of what their needs are for management and therapy. The other way to look at adult congenital heart disease is on a spectrum based on their presentation and also based on the types of lesions. So I think this is a helpful way to look at these patients. I consider the patients as either a patient who has new disease, known unrepaired disease, or repaired disease, and these patients can behave differently. So in new disease, a lot of times you'll see patients in the adult population that either have an incidental finding, for example, a patient who has a stroke and they're looking for paradoxical emboli and they get an echo and they identify an atrial septal defect. Or it could be a patient who's presenting with that diagnosis as new disease. So for example, it's a patient presenting with a dilated right heart who's diagnosed with pulmonary anomalous pulmonary venous connection. In terms of the second category, known unrepaired disease. So there are patients who have known disease but don't meet an indication yet for treatment. So a good example is there are many patients with bicuspid aortic valves, which is considered congenital heart disease, that are being surveillanced because they don't have significant aortic stenosis or insufficiency, so they're being monitored. And then there's also patients with known disease that's unrepaired that unfortunately now has a contraindication for treatment. So an example would be a patient with an ASD who has pulmonary hypertension that unfortunately has Eisenmenger syndrome. And then there's a large number of patients with repaired disease, which you'll encounter. And when you think of patients who have repaired disease, you should think of them in two ways. You should think about them in terms of what are their known needs for future intervention. So for example, a patient with a tetralogy of Fallot repair with a transannular patch will have lifetime need for pulmonary valve replacements. And then there are patients who have a palliative circulation, for example, a Fontan circulation, which is palliative, and you need to think about what are the possible sequelae of this end-stage disease. And one of those would be transplantation. And then you can also look at the disease in terms of categories. And so I'm not going to go over all of these, but I think it's important to understand that you can think of them based on their pathophysiology. So there are a series of lesions that are called shunt lesions. So ASD, with atrial septal defect, partial anomalous pulmonary venous connection, ventricular septal defect, atrioventricular septal defect, and a patent ductus arteriosus. And we'll talk about these as some of the more commonly encountered lesions. And then there's left-sided obstructive lesions. Coronary atriatum is less common. You can have congenital mitral stenosis, subaortic stenosis, aortic and supravalvar and coarctation. And then you can have right-sided lesions. So you can have pulmonary stenosis, double chamber right ventricle, Epstein's anomaly, tetralogy of Fallot. And then everything else really falls into complex lesions. So all the different variants of transposition of the great arteries, all the different single ventricle physiology, including hypoplastic left heart syndrome. You have truncus arteriosus, double outlet right ventricle, pulmonary hypertension, and coronary anomalies. So the ones in bold are the ones that I'd like to focus more on for the remainder of this talk. So the first commonly encountered lesion is an atrial septal defect. So here's a diagram, and an atrial septal defect in simple terms is a hole in the upper chambers of the heart. In general, your left heart is a higher pressure system than your right heart, and your ASD flow is based on the compliance of your ventricles. So in general, you will have a left to right shunt across that ASD, and that will cause right heart volume overload. And so you have left to right shunt, you have increased volume on the right heart volume overload, and increased pulmonary blood flow. And that's the pathophysiology of an atrial septal defect. To get a little more complicated, there are actually 6 different types of atrial septal defects. The first is a patent foramen ovale, which most of you are familiar from. It can be an embryological persistence. The most common is an ostium secundum defect, and that's typically isolated. An ostium primum ASD is that which is associated with an atrioventricular septal defect. A sinus venosus ASD is associated with anomalous pulmonary veins. An unroofed coronary sinus is usually associated with a left superior vena cava. And a common atrium where you really have no atrial septal wall is more associated with heterotaxy syndrome. So in general, all of the ASDs behave in a similar fashion. And I think it's important to contrast how they present in a child versus an adult. And the focus of this is the adult manifestation. So really in a pediatric patient, oftentimes they're asymptomatic. They might get picked up with a murmur or right heart dilation. And oftentimes they're being closed electively. And an adult, oftentimes they're getting picked up when the patient has symptoms because it's more long-standing disease. It can get picked up in unique ways. It's a patient who has a paradoxical emboli. It's patients who develop arrhythmias because they have right heart dilation. They can have exercise intolerance as a result. They can have right heart failure. And I've actually seen patients getting a lung transplant for Eisenmenger syndrome from unrepaired ASDs as well later in life. So here it's a busy slide, and I don't want to focus on all the details, but on the left, I have the guidelines and recommendations for treatment with the level of evidence, but I really want to focus more on the flow sheet to the right. And for all of these shunt lesions, you'll see that they follow a similar format. So just in general, the indication for an operation for any of the shunt lesions later in life is a patient who has symptoms. So that's one, if you're symptomatic. Or it's if you're not symptomatic, it's to prevent the complications of disease, and you have to rule out those complications. So the way I like to think about all of these patients is if you have a patient with a large ASD and they're symptomatic, that's an indication for operation. If they're not symptomatic, then you look to see, is there a reason that I can't close this defect? And so you have to rule out that you have no contraindication. So starting at the top, you have a secundum ASD, and you look at the shunt direction. So in general, if a patient has left to right shunt and they have normal saturations, you're less concerned about pulmonary hypertension and pulmonary vascular changes, because if somebody has an elevated pulmonary vascular resistance and they have right ventricular decreased compliance, then they might start to right to left shunt. And you might see that with cyanosis on exam and also right to left shunt on an echo. So if you go to the left and you have a left to right shunt, you assess the hemodynamics. And so here, this algorithm is saying that if your PVR is less than 1/3 systemic, if your PA systolic pressure is less than 50% systemic, if you have right heart enlargement, and the shunt is large enough to cause sequelae, so they use a QP to QS of greater than 1.5 to 1. And in all actuality, we don't routinely measure this with functional MRI or cath. And if you have functional impairment, they say whether or not you have that, recommendation is for device closure. With hemodynamic assessment, if you have a little higher pulmonary vascular resistance, a little higher PA pressures, still the recommendation is after consultation to close those defects. It's really the patients on the right that have a right to left shunt where you don't want to close them because you worry that if you close the ASD in the setting of a right to left shunt, that you can then have pulmonary hypertensive crises. Now, in some of these patients, they might be responsive to pulmonary vasodilator therapy. So you could take them to the cath lab to do vasoreactivity testing or start them on pulmonary vasodilators. And then if they go from having right to left shunt to left to right shunt, then you might have caught them in a window where you can close the ASD and then treat them for their pulmonary hypertension after. But in general, this is the approach for most of these shunt lesions. So in terms of treatment options, the options are either catheter-based or surgical. For catheter-based closure, it's important to have adequate rims for the device to seat and to avoid adjacent structures. So I provided 6 different types of ASDs. In reality, a patent foramen ovale and secundum ASD are amenable to catheter-based closure. And more recently, some people have been trying to close sinus venosus defects that have anomalous pulmonary veins as well. And for surgical closure, really all types are available. So this is just an example of a catheter-based closure of an atrial septal defect. There's different devices on the market, but this is one type of Amplatzer device, which really looks like a dumbbell. And I think what's important to see is that you need an adequate rim, and those rims can be evaluated on transthoracic and more importantly on transesophageal echo. In terms of a surgical closure, this is a surgeon's view. So this is the superior vena cava. This is the inferior vena cava, the right-sided pulmonary veins, the coronary sinus, and this is a secundum atrial septal defect. And then that would be closed with a patch. You can really use any patch material. My preference and our institution's preference is to close this type of ASD with a Gore-Tex patch just because it's easy to work with and reliable, but others use autologous pericardium and really anything that you'd like. In terms of the risks and outcomes, in general, the outcomes are quite good with either of these, but for catheter-based closure, I think things that are important to keep in mind there are vascular access complications, contrast nephropathy, and then specific to this procedure, you can have migration or embolization of the device, and that's where those rims become important. So oftentimes the aortic rim is insufficient, and so if you have an insufficient rim and you try to deploy the device, you could have it embolized. There's also reported cases where you can have erosion because really the ASD is in close proximity to the aortic root. And if you put this device against there with an inadequate rim, you can erode to the root. And then there's also reported cases of thromboembolism. So typically these patients are on some type of antiplatelet therapy for a period of time until there's endothelialization so that you don't form thrombus that embolizes on the device. And in terms of surgical closure, there are the standard surgical risks, standard risks of cardiopulmonary bypass, and then there's the risk of a residual defect. The next lesion I'd like to talk about is a ventricular septal defect, or VSD. So this is a hole in the lower chambers of the heart, and in a similar way to the ASD, it typically creates a left to right shunt, and this is actually based on the pulmonary and systemic vascular resistance, not the right ventricle and left ventricular compliance. And there are 5 different kinds of ventricular septal defects. There's and I will just say that depending on the textbook you read and where you train, the nomenclature can be quite different. And so actually there's a lot of variability in how people name these. But in general, there are perimembranous defects, which are most common. There are inlet defects, which are right underneath the atrioventricular valve, and those are associated with atrioventricular septal defects. There are outlet defects or conoventricular defects or subarterial or supracrystal. There's a lot of different names, but these are usually associated with conal truncal anomalies like tetralogy of Fallot, double outlet right ventricle, transposition, and truncus. There are muscular defects, and the location of these is important. You can have anterior muscular, apical muscular, posterior. They're in a lot of different locations. And based on where they're located, they can be challenging to localize and close, especially from the right ventricular side, which is heavily trabeculated. It's hard sometimes to tell where the defect is versus normal trabeculations. And then you can actually have multiple VSDs that can be mixed type. The VSD I did not discuss here is a post-infarct VSD, which is really more something that occurs after a myocardial infarction and is managed by adult cardiac surgery. In terms of the presentation, again, it's important to note that the presentation can be different and is different with a pediatric versus adult patient. The typical story for a pediatric patient is they're symptomatic from a large left to right shunt. They have left heart dilation, heart failure, which leads to failure to thrive. These children either have to choose to breathe or eat, and they choose to breathe. And so this is the classic presentation for them. And they get fixed at about 4 to 6 months of age, unless they're symptomatic sooner. In an adult, oftentimes they're not having a large VSD, because if they did, they'd be more symptomatic earlier in life, but they can be symptomatic, but they can also develop these other unique findings. One is endocarditis. The reason for this is that with a restrictive ventricular septal defect, you have a turbulent jet that can hit typically the septal leaflet of the tricuspid valve. And when that occurs, you can develop endocarditis of the tricuspid valve. The other is that as these defects close, the tricuspid valve, the aortic valve, and the VSD are in very close proximity to each other. So oftentimes the right cusp of the aortic valve can prolapse into the defect, and you can start to develop aortic insufficiency, which is an indication for operation. You can also develop double chamber right ventricle associated with these kinds of VSDs. And if left untreated, a large left to right shunt can also lead to pulmonary hypertension. So this again are the guideline recommendations from the 2008 guidelines. They're similar to ASD, which is why I don't want to go over all of them. But again, looking at this diagram on the right, if you have a significant ventricular level shunt, you again look at the direction. If it's a left to right shunt, then you assess the hemodynamics. So again, if you don't believe that you have pulmonary vascular changes, you have a low PVR, low PA pressures, and a large shunt, then closure is recommended. If you have progressive aortic insufficiency, that's also an indication. And if you have a history of endocarditis, it's also an indication. And then on the other end, if you have more severe disease, but it's not prohibitive to closure, then again, consultation with the experts and closure is still recommended. It's really when you have end-stage disease with right to left shunting, where you have pulmonary hypertension that's prohibitive, that it's contraindicated. So again, the treatment options can be catheter-based or surgical. Again, with catheter-based closure, you need to have adequate rims and you need to avoid adjacent structures. So catheter-based closure is most commonly done for muscular VSDs. With these VSDs, they're farther away from conduction tissue. They're farther away from the atrioventricular valves or the semilunar valves. So they're in a place that's more amenable, where all of the other VSDs can be closed with surgery, either through a transatrial or ventriculotomy approach. So it's preferable to close these transatrial. So that means making an incision in the right atrium, looking through the tricuspid valve into the right ventricle and closing it from the right ventricular side, versus a ventriculotomy. And the reason for that is when you make a ventriculotomy, you create scar tissue. It can affect the function of that ventricle, and it can also be arrhythmogenic by forming scar there. So when possible, we like to avoid ventriculotomies, but in some cases, a right ventriculotomy is required, or in the case of an apical muscular VSD, a left apical ventriculotomy might be required. So there is a lot of appeal to a more hybrid approach, which is called a per-ventricular device closure. So what that is that we do a median sternotomy and we provide access to the interventionalist. So we place catheters for them. And so it's a per-ventricular approach to allow them to then deploy devices through muscular defects. So this is an example of a catheter-based closure. So you can see here, this is a 4-chamber view, a right atrium, left ventricle, right ventricle. This is the ventricular septum, and this dumbbell-shaped device is closing a VSD. In terms of surgical closure, it depends on the location. This is showing you a transatrial approach. So you see here that you have your SVC or right atrial cannula, your IVC cannula. You're looking from the right atrium through the tricuspid valve. This is the septal and anterior leaflets of the tricuspid valve, and this is a perimembranous defect that sits right underneath that valve. And this defect would typically be closed with a patch. In terms of the risks and outcomes, again, the outcomes are quite good for a ventricular septal defect closure. The catheter-based closure complications or risks are the same as for the ASD, and so kind of nothing specific to this one. In terms of surgical closure, it's the same risks of doing any operation or using cardiopulmonary bypass, but depending on the location of the VSD, we're close to the conduction system, so there's a risk of complete heart block, and also damage to surrounding structures, including the tricuspid and aortic valve, and the possibility of leaving residual defects, especially with muscular VSDs. Next, I'd like to talk about atrioventricular septal defects, or AVSD. So this is essentially a hole in the center of the heart, and you can have abnormalities with the atrial septum, the ventricular septum, and the atrioventricular valves. So they're defined based on that, and they're defined either as incomplete, also known as partial, or an ostium primum ASD. And that has an ASD component, but there's a separate left and right AV valve. So we don't call them mitral and tricuspid valves because they're really not, and they vary. So to be accurate, nomenclature-wise, we call them a left atrioventricular valve and a right atrioventricular valve. But in this case, they have a separate annulus. And then there's typically a cleft in that left AV valve. Transitional is an ASD with separate valve annuli, the same cleft, but the presence of a ventricular septal defect. And then a complete AVSD has an atrial and ventricular septal defect, but it's one common AV valve. So it's one annulus that has the left and the right AV valve with a cleft in the left AV valve. In terms of the presentation of these patients, again, pediatric patients present in the same way as a patient with an ASD or VSD. And so they're typically symptomatic. They get left heart dilation and heart failure with failure to thrive, and they're repaired earlier in life, typically at about 4 months of age. In an adult patient, they can be symptomatic, and they can be symptomatic for one of 3 reasons. Either from the shunt, if they have a large left to right shunt, they can have left heart dilation. They can also be symptomatic from having left AV valve regurgitation because these valves are not normal. Oftentimes these patients can present with essentially mitral regurgitation. And also because of the hole in the center of their heart, their left ventricular outflow tracts are abnormal. They tend to be elongated, which is a setup for having left ventricular outflow tract obstruction. And then the sequelae of end-stage disease from an unrestricted left to right shunt is pulmonary hypertension again. So in terms of the indications, again, it's similar indications as an ASD or VSD, but in addition to that, there are indications based on having mitral regurgitation, similar to the adult guidelines, and also for having left ventricular outflow tract obstruction. In terms of the treatment options, they're surgical in this case, and there are 3 ways to repair these. There's what's known as a single patch technique, which I'll show on the next slide, a modified single patch, which is known as the Australian technique, where it was popularized, and then a 2-patch technique. Regardless of the technique, the goal of this operation is to septate the heart. So that means close the ASD, close the VSD, separate the AV valves into a right AV valve and a left AV valve, and then repair the valves. So this is showing a complete AVSD on the left. So this is a common AV valve. So it's one valve annulus, And then these leaflets comprise the right and left components. So this is a double patch repair. What that means is you use one patch to close the VSD, a second patch to close the ASD, and you essentially sandwich the common AV valve between the two patches to separate it into a left and right component. And then these are tri-leaflet valves on each side, but as you know, the mitral valve is a bi-leaflet valve. So you close the cleft here to create an anterior leaflet and a posterior leaflet. And then a modified single patch repair, you don't put a VSD patch, you just put an ASD patch, and you essentially bring down the AV valves to the level of the crest of the ventricular septum. So you're essentially closing the VSD primarily in this fashion. And then the one patch, which is not shown, is actually cutting the AV valves, putting one patch, and then reattaching them. There are early and late risks with this operation. The early risks are similar to that for a VSD. The late risks, and it's important to know this if you're managing these patients, is that there's about a 5 to 10% risk of having left AV valve regurgitation that requires additional valve repair or replacement. And similarly with left ventricular outflow tract obstruction. Oftentimes these patients can have complex forms of subaortic stenosis. They have an elongated outflow tract. They have secondary cords. They can have small left-sided structures and a small aortic valve. Next, I'd like to talk about partial anomalous pulmonary venous connection, or PAPVC. So this means that the pulmonary veins, instead of draining to the left atrium as they should, drain anomalously to the right side of the heart, and they can drain to multiple locations. This example is showing one of the more common ones where the right upper and right middle pulmonary veins are draining to the superior vena cava. So you can have a partial anomalous pulmonary venous connection, which can be any vein. Again, the right upper is most common. A special type is called scimitar syndrome, which is really more seen in the pediatric population that I won't discuss here. You can have a mixed type, or you can have total anomalous pulmonary venous connection. This is typically seen in the newborn period and can be either supracardiac, meaning that the veins connect above the level of the heart, cardiac at the level of the heart, infracardiac below the level of the heart, and they can be obstructed or non-obstructed. Obstructed total veins is a surgical emergency and typically corrected within the first 24 hours of life. So this doesn't pertain as much to adult congenital heart disease. The presentation, again, in pediatric patients is usually asymptomatic. It presents like an ASD. And an adult patient, they can be asymptomatic. And surprisingly, these patients can present quite late in life. We've seen patients that are 60 or 70 years old that are getting diagnosed with this, or they can be symptomatic from having long-standing left to right shunt. This is a group of patients that are important to think about. If you have a patient who has right heart dilation without a clear etiology, meaning they don't have any tricuspid valve regurgitation, they don't have a cardiomyopathy, they don't have any atrial septal defect, and you're perplexed why they have a dilated right heart, I would look for anomalous pulmonary veins. It can progress, and patients can have right heart failure, exercise intolerance, and again, pulmonary hypertension. The recommendations are very similar to the other shunt lesions. And the treatment can involve different approaches depending on which veins are involved and where they're located. So just to focus on the typical scenario that you'll see most commonly, and that's when the right upper and right middle pulmonary vein drains to the superior vena cava or the junction of the superior vena cava with the right atrium. And so in that case, you can repair that with 1 or 2 patches. So what you do is you put a patch that essentially bisects, and I'll show you a picture on the next slide. So I'm going to just show you the picture and go back to this slide. So here you see you have anomalous veins that are entering the cavoatrial junction. You make an atriotomy, and then typically it's associated with an ASD. Sometimes it's not, and you have to create an ASD. but you need to get the anomalous pulmonary veins to go through the ASD to the left heart. So we call that baffling the pulmonary veins through the ASD to the correct left atrium. And you place a patch to do so. So this patch essentially bisects the SVC. You have an anterior portion that carries the blue blood and a posterior portion that carries the red blood. And at the same time, you close the ASD. Now, if you do this, you run the risk of obstructing either the pulmonary vein or the systemic vein baffles. So in some cases, what you do is you put a second patch to patch the superior vena cava. So here they show the right atrial appendage doing that, but you can put a second patch to prevent SVC obstruction. Now, if these pulmonary veins are very high up, you have to make a much longer baffle and you're more at risk for obstructing. So there's a procedure called the Warden procedure, where you essentially transect the SVC and you keep the stump as a conduit for the pulmonary veins to go to the left heart. And then you take the right atrial appendage and you connect it to the SVC. So again, a 1 or 2 patch technique, a Warden procedure. And typically when there are anomalous left veins in an adult patient, sometimes you have to do a direct reimplantation, but the principles are the same. Get the pulmonary veins to the left side and close any ASD. So the one risk of note with this is that you can get sinus node dysfunction when you're working near the cavoatrial junction because the SA node and the SA nodal artery are in that area, and you can also have baffle obstructions. Next, I'd like to talk about PDA just briefly. So patent ductus arteriosus, it's a remnant from embryologic circulation. In small babies, you usually see it in NICU kids where they have pulmonary overcirculation, they're stuck on the ventilator, they have systemic hypoperfusion, necrotizing enterocolitis. In adult patients, it's less common to see, but you can also have a large left to right shunt. You can have endocarditis from a restrictive duct with a turbulent jet. You can get aneurysms and pulmonary hypertension. Same indications as with the other shunt lesions. And there's catheter-based closure and surgical closure. In general, surgical closure is challenging because adult ducts are calcified and fragile. You can't ligate them, so you typically need to patch close them from the pulmonary end and sometimes under circulatory arrest. So generally, they're closed in the cath lab with a device. So now to touch on pulmonary valve replacement. So I give you a picture here of tetralogy of Fallot, status post a transannular patch. So this is a child who had a tetralogy of Fallot repair where their pulmonary valve annulus was too small. So we had to cut across the pulmonary valve annulus and place what's called a transannular patch. So you leave them with a pulmonary valve that's not competent. Now that's remarkably well tolerated for a long period of time. So we choose not to place a pulmonary valve at the time of repair because it will lead to us coming back sooner, because if you place a pulmonary valve in an infant, it'll degenerate quickly and you'll be back to replace it. So they tolerate pulmonary insufficiency and we watch them. So it's important to know with pulmonary valve what the outflow track is like and what's been done before, because that dictates the management. So you can have a native outflow track like the picture I showed where it's just patched. A native outflow track where you have an intact annulus, but you have a pulmonary valve that may have been ballooned with severe pulmonary insufficiency. You can have one like I showed you with a transannular patch. You can have a pulmonary valve replacement with a tissue bioprosthetic valve already present, or you can have an RV to PA conduit. So that's in a heterotopic position. On presentation, these patients can either present with pulmonary stenosis or pulmonary insufficiency or a mixed picture. So if they have pulmonary stenosis, they can have a pressure-loaded ventricle. If they have pulmonary insufficiency, they can have a volume-loaded ventricle, which is more typical, where they can get RV dilation, which can lead to breast function, arrhythmias, exercise intolerance, and heart failure. So again, here's an algorithm and indications for when to repair a pulmonary valve, but it's important to know that we like to wait to optimal timing because this is a lifelong problem. With the current technology available, pulmonary valves in an adult will last 10 to 15 years on average. And so you don't want to put a pulmonary valve in too soon, because you're going to be back to either the cath lab or the operating room to replace it. So if our goal is to get these patients to live the longest they can with the least number of interventions and best quality of life, we need to be creative in terms of timing and how we approach this. So we basically watch these patients and we follow them with echo and MRI. And the MRI is helpful to look at indexed right ventricular end diastolic volumes. And if patients are symptomatic or they start to have evidence of an RV that's struggling or that's progressively dilating, that's the timing for intervention. Same thing with a right ventricle to pulmonary artery conduit. And so if you decide that a patient needs a pulmonary valve, it can be approached either catheter-based or surgical. Sometimes in the cath lab, if it's a stenotic valve, we choose to have them balloon angioplasty it or place a stent to buy some time, or to place a valve with either a Melody, Sapien, or Harmony valve. Or we can do this in the operating room with a pulmonary valve replacement or RV to PA conduit. And we typically use tissue-based valves, either homograft or a tissue bioprosthetic valve, like a stented valve. An aortic magnet ease valve that you'd see for an aortic valve replacement is typically what's used. And so we like to be creative. And so a lot of times we'll place a surgical valve and then have the interventional cardiologist then place a valve and valve, or a valve and valve and valve after that, to avoid the number of open heart procedures. So this is showing on the left a transcatheter pulmonary valve with a Melody valve, a surgical pulmonary valve with a stented bioprosthetic tissue valve, and then an RV to PA conduit with either a tissue valve inside of a HemoShield graft or a pulmonary homograft. The risks, again, there are risks with both. Some specific risks to this is that if you have a heavily calcified conduit or pulmonary transannular patch, you can have rupture. The other thing that's important to know is that the coronary artery, specifically the left main coronary artery, runs posterior to the pulmonary valve annulus. So routine is that they balloon occlude first and they test to make sure there's no coronary artery compression before deploying the device. And that with some of these, like the Melody valve, the literature, at least earlier, had suggested that there's a higher incidence of endocarditis. In terms of surgical risk, it's the same risks. There's also risks of a redo operation. A lot of these patients, especially with conduits, might be a 4th, 5th, 6th time redo. So these can be challenging operations. I just want to briefly touch base on coronary artery anomalies, because this is something that you'll see in the adult patients, and I just want you to be aware. So there are a lot of different types of coronary artery anomalies. And I've listed them in different categories. There are those that are associated with transposition of the great artery, and this is more relevant in the pediatric population with an arterial switch operation. There are patients with tetralogy of Fallot that have expected variations. Oftentimes they have counterclockwise rotation of their right coronary artery. They can have dual left anterior descending arteries and large conal branches that are relevant surgically. There are patients with anomalous aortic origin of a coronary artery, which we'll talk about on the next slide. Patients with anomalous coronary arteries that come from the pulmonary artery. And the most common is what's called L kappa. And this is interesting in that it has a bimodal distribution. It's oftentimes seen in about 3 to 4 month old patients, and then it's seen in adult patients as well. And so this is where the left coronary comes from the pulmonary artery. And then there are a lot of miscellaneous lesions like single coronaries, intramural cores, coronary artery fistulas, and sinusoids. So I just wanted you to make you aware of these anomalous aortic origins. So here you have an anomalous left coronary from the right sinus. This is an anomalous right from the left sinus. And this is an intramural coronary. The reason that these are important is that they take a different course, and that can lead to different angulation and can lead to compression or ischemia. So these patients can be asymptomatic, which most times they are, but they can also present with angina, ventricular arrhythmias, sudden cardiac death, and actually postmortem. So in studies looking at military patients that had non-traumatic death, a lot of times they find these anomalous coronaries on postmortem examination. So in general, the recommendations are that if you have symptoms and you have an anomalous aortic origin of the coronary, if it's a left off the right, you repair it. If it's a right off the left, you repair it. The question becomes, if they're not symptomatic, what you do. So oftentimes you'll get stress imaging to see if there's any evidence of ischemia. If there's evidence of ischemia, you repair it. If they're not symptomatic, there's no evidence of ischemia, then you look for high-risk features. So if they have slit-like orifice, depending on the course that they take, you might say that they're at greater risk and you might consider it. And so typically, people are more likely to offer this operation for an anomalous left than an anomalous right. But the problem becomes when you diagnose this is that then you exercise restrict a lot of these patients. They're aware of it. And so this is an important discussion to have with the families. The other thing to know is that we don't know for sure if this changes the trajectory and the prognosis of these patients. So even when you treat these, they might still have the same risk profile after. And so the repair is basically unroofing the coronary, or you can translocate or reimplant it with the goal of unobstructed coronary flow. I know I'm running just a minute or two towards the end. I'm almost done and we'll have time for questions. So this is just an example of an anomalous left from the right sinus, and it's taking a long course within the wall. And so here you actually unroof that portion. And the important thing to know is sometimes you have to take down the commissure of the aortic valve in order to do that. So this operation is not without risk. You can injure the coronary, you can dissect the aortic wall, you can cause aortic insufficiency. And so it's weighing the risks and benefits. So in conclusion, adults with congenital heart disease are a challenging and complex group of patients to care for. They present differently than children, and it's important to recognize that difference in presentation so you can identify it. It's very important to approach these patients with a multidisciplinary approach, and it's important to involve adult congenital cardiologists and surgeon in the care of these patients, to follow guideline-driven approach to care, to provide the current standard of care. And I believe these patients get the best approach when it's a dual approach of catheter-based and surgical treatment. And the field will continue to only grow as more and more children survive and these adults are living longer into adulthood. These are the references. And I just want to point out, and this again is not inclusive, but this is our Detroit Medical Center team that's involved heavily in adult congenital heart disease. So my partner and the chief of pediatric cardiovascular surgery, Dr. Mamdouh Alamadi, and this is myself. And then on the adult cardiovascular side, Dr. Kenton Zier, who's joining us on this panel, Dr. Mandal and Dr. Terasaki. Interventional cardiology, Dr. Fagan is our chief of pediatric interventional cardiology, and Dr. Al Reyes is on the call as our panelist. And then Dr. Karpowicz, Gupta, and Shuram are our three adult congenital cardiologists within pediatric cardiology. I'm happy to take any questions, and feel free to reach out to me by email or phone with any questions that you have, and I'd be more than happy to answer them. Thank you for your time and the opportunity to present.
Thanks so much, Peter. What a beautiful, inclusive presentation.
Thank you.
And it was a lovely educational experience for myself as well, because I don't think of these things like you do in such a complex way. I wanted to ask, things have changed dramatically over the last 20 years in terms of potential catheter-based interventions. And I just wanted to ask, how much agreement is there in what the path should take? Or is it pretty much a foregone conclusion when you present a patient, what therapy should that patient get? Or is there sometimes disagreements between the surgeons and the catheter-based interventionalists as to when and what and where?
Yeah, I think that's a very good question. You know, I think both in my previous institution and here, it's a rather collaborative approach to these patients. You know, in general, you know, for an ASD, for example, oftentimes, unless the patient objects to it, if they're a candidate for catheter-based closure in an older patient with a secundum ASD, they'll be offered that as first-line treatment. And oftentimes will be available on standby. So sometimes what will happen is they'll go to the cath lab, they'll get a TEE, they'll determine there's insufficient REMS, and then they'll bring the patient to the operating room. So for a lot of the defects, we will offer catheter-based as first-line therapy. I think really where you're asking is more kind of valve replacements. And
exactly. So I'm like, you know, when do you send the patient to a surgeon for a you know, an RVPA conduit as opposed to, say, a risky valve intervention on a stent?
Yeah. So in general, with the goal of trying to minimize the number of open heart procedures, because again, we have patients that are 4th, 5th, 6th, 7th time redo operations with quite complex anatomy, we try to get the most we can out of a conduit or a pulmonary valve. And so we'll try to have them rehabilitate that the best that they can to buy some time. So that's where a lot of times with the conduit, it'll become stenotic. We'll have them balloon dilated, even though they'll have pulmonary insufficiency, it's well tolerated. We'll even have them put a stent in. And then if they can put melody valves inside of that, that would be advantageous until they get to a point where we have to take everything out, give them a new conduit to start with. So that's the way that we really counsel the families as well. With a pulmonary valve replacement, at least with the Melody and the Sapien, a lot of times what was happening is that patients back in the day had large ventriculotomies and large transannular patches. So their RV outflow tract and landing zone was too large for the available valves. So now the Harmony valve, which is expandable, is allowing some valve replacement in a native outflow tract. But in general, the patients are usually getting a surgical pulmonary valve replacement for their first replacement. And then after that, they're getting a valve in valve. And so when we pose that to families, really what we would like to see in an ideal world would be we place a valve and they can get 1 or 2 valve and valve replacements. So we hope to get them, you know, say 30 years before they're coming back to us for their next replacement.
Because there is a couple of questions coming from the audience as well.
Yes.
We are over time. How AVSD is dealt in children with Down syndrome? Any changes in surgery of AVSD in DS group?
Yeah, that's a very good question. Thank you. So I didn't mention that AVSDs are heavily associated with trisomy 21. So in general, in the pediatric patients, it's actually favorable from a surgical standpoint. So the Down syndrome patients typically have more consistent and reliable anatomy. Their atrioventricular valve tissue tends to be a bit more robust and easier to work with. So from a surgical standpoint, it's a more favorable AVSD to deal with. Now on the downside is their trisomy 21 and the comorbidities associated with that. They're at increased risk for having accelerated pulmonary vascular changes. They have sleep apnea. They're more difficult to manage. And so that's kind of where the trisomy 21 comes into effect, but it doesn't really change our indications or approach to management for those patients. That's a good question. Thank you.
Yeah. The second question is, what is the current practice for PFO closure and cryptogenic stroke?
Yeah, that's a good question. I'll be honest with you on that one. I'm not current on the available literature on that. To be honest, most of those patients don't ever see us surgically. If they're having a PFO closed, it's going from that evaluation to the cath lab. I should know the literature better. I certainly can check that up and reach out to you offline. Dr. Arez, do you have experience with that on the adult side?
Well, as you know, Dr. Thomas Forbes has been a great educator on that sphere, but for cryptogenic stroke, for somebody who are completely ruled out as an adult for any underlying arrhythmias such as AFib with a Holter monitor or event monitor for a month, and there is no evidence for arrhythmogenic source for stroke, and the PFO is still showing shunting. So the current guidelines, based on the meta-analysis summarizing 5 major trials, the last one was a total, is suggesting that closure decreases risk of stroke compared to antiplatelet therapy alone. So we have been doing screening, for example, for anybody coming with stroke, and there is no especially younger age. If there's a PFO and there is no arrhythmias and PFO is confirmed, we refer them for closure.
Great. Yeah, that was my understanding, but I haven't reviewed that literature recently, so thank you.
Yeah.
In the past, a lot of programs, typically some of the programs I was trained, like I trained at Hopkins, and then I spent a lot of my career at the Mayo Clinic. And these programs don't have a separate children's hospital, or didn't when I was training. So a lot of these lesions, such as adult congenital TETs, or even patients, say, with coronary anomalous coronaries, they kind of found the person within the group who had maybe the most experience dealing with it. What is your feeling now about how the referral pattern should go, say, for coronary anomalies that are discovered in 40 and 50 and 60-year-olds?
Yeah, I think
I'm putting you on the spot here because it's a difficult, like I do most of, when they come to me, I do them. But, you know, I've also read Chuck Fraser's kind of definitive article out of Texas Children's, who's very, very particular about which operation should be done for which ones. And it's not necessarily the operation that I'm doing. So I'm wondering, am I doing the patient a disfavor by not asking you to be in my operating room?
Yeah, no, I think Dr. Zer, that's a great question. That's why I put on that one slide, you know, who it should be performed by and in what setting. There's no right answer to this question. I think every adult congenital program struggles with this. Who's best to manage the patient? Where are they best managed? And there's certainly, pros and cons of both. My personal practice has been that I think it's good to engage an adult cardiac surgeon and to do things in a joint fashion. I think that, we both come with a different perspective. And so, I was in a setting before and like a setting here where, we're just next door to each other. So it's easy for us to work together on cases. I think, in anomalous coronary, I feel very comfortable that you're probably very good at doing that. I think when it comes to more complex disease, sometimes when the anatomy is different, that can be challenging, and having a congenital perspective is helpful. I think having those discussions and kind of multidisciplinary conference can help iron some of those things out. So I'm reluctant to say that, it should be done this way or that way. I think it really depends on the patient and also the setting you're in and the resources that are available.
Well, I think we are really coming to a closure, and thank you so much. This has been very insightful webinar, Peter, and I appreciate your input as well as the very fruitful techniques for the surgical intervention for patients with congenital heart disease. Last point is, just want to make sure the audience is this is a 1 hour CME activity, and please, we're going to get a survey in the mail and the email there today or tomorrow to fill the summary of and your feedback on the webinar. If you have any, again, question or transfer for adult or congenital transfer, please call this number 313-578-6767. I would like to thank again Dr. Desalos as well as Dr. Kentenzer for a wonderful hour and evening, and please stay tuned for our next webinar for next month. Again, it's the 4th Thursday of the month at 7 p.m. coming to you from DMC Medical Group Heart to Heart. Watch these webinars and others on the YouTube channel where we're going to be editing and hosting these webinars that are available back again if you'd like to review them in the future. Again,
and thanks so much.
Thanks
so much, Chadi. My computer died, so I just wanted to give my regards and the sign off.
Thank you so much, Dr. Cesalos. Appreciate your time and expertise today, and have a good evening, everyone.
Thank you so much for having me.
I hope you have enjoyed this DMC Medical Group video. To find more content, webinars, and physician videos, visit dmcmedicalgroup.com.